Hello, everybody. Today, we're diving into one of the most influential healthcare models shaping systems worldwide, the Beveridge Model. We are focusing specifically on the Beveridge Model as it applies to the United Kingdom. Myself, my colleagues Jordan Finney, Julia Brigado, and Nick Moreau will be helping me present the information surrounding not only the effects that the Beveridge Model has in the UK, but also areas and other countries around the world. A couple things here. The Beveridge Model is also known as the National Health Service Model. The model was originated in the United Kingdom and has influenced various countries, creating systems centered around universal healthcare, access, and affordability. And we'll just move on to this next slide here. So in healthcare, the Beveridge Model stands out because it aims to make healthcare accessible for all citizens as a basic right, rather than a service that is based on one's ability to pay. So let's explore the key features of this model and how it serves as a foundation for universal healthcare in several countries worldwide. So to start off with, the Beveridge Model is often considered the framework for tax-funded healthcare. Named after the British social reformer William Beveridge, this model was designed to reduce the financial burden on patients and ensure that healthcare is available for all. In fact, some people call it the National Health Service Model because it was developed in the UK through the National Health Service, or as it's known as the NHS, which was founded in 1948. Since then, it has inspired various countries to adopt similar healthcare structures. And we're going to go ahead and break down what makes this model unique. One of the defining features of the Beveridge Model is its funding structure. Unlike systems that rely heavily on private insurance or direct payments, the Beveridge Model is primarily funded through general taxation. This means that the healthcare system is supported by taxes the population pays instead of insurance premiums or fees at the point of care. Why does this matter? Well, tax-based funding reduces financial barriers, makes healthcare accessible for everyone, and people don't have to worry about how they're going to afford a visit to the doctor or a hospital stay because those services are funded through taxes, which everyone contributes to based on their income. So it's a shared responsibility. It's an approach that spreads the financial load across its society, in this case, the United Kingdom. Another major benefit of the Beveridge Model is the low out-of-pocket expenses for patients. In this system, people typically face very low or no cost when receiving care. Imagine needing surgery or having a major medical event and not having to worry about the cost of treatment. I know that a lot of Americans could probably look at that and find it somewhere in their dreams. So the Beveridge Model ensures that people don't have to choose between their health and their finances. By reducing these out-of-pocket costs, the Beveridge Model significantly reduces economic inequality in healthcare access. As well, in this model, everyone, regardless of income level, can access essential services without facing financial hardship. So as you can see, there's a major theme as to one of the characteristics of this model is equity when it comes to financial access, but also the financial hardships and the lack thereof. This principle has far-reaching effects on health equity, reducing the gap in health outcomes. It's often seen between wealthier and lower income population. So now that we've looked at that, let's now look at the role of the government in the Beveridge Model. In many countries with this model, like the United Kingdom, the government not only funds healthcare, but also manages and operates healthcare services. This includes owning hospitals and healthcare facilities, and in some cases, directly employing healthcare providers. So not only are they owning the buildings, but the doctors are federal and practitioners are considered government employees. This centralized control allows the government to monitor healthcare costs, allocate resources, and set national standards. Because of this, the Beveridge Model can provide standardized care across the country, ensuring that everyone receives the same quality of care no matter where they live. Centralization also allows governments to focus on broader health goals like improving population health and preventing diseases instead of just treating illnesses as they arise. So it's more of a proactive instead of a reactive approach. This management approach makes it easier for countries to coordinate their resources, control costs, and reduce duplication of services, which is particularly important for achieving efficiency in healthcare delivery. And we'll move on to this next slide here. Which talks about accessibility. And so as a core mission of the Beveridge model, it is to ensure accessibility and equity in healthcare. Universal coverage is a cornerstone of this model, which means that everyone, no matter their income, occupation, or social status, has access to essential healthcare services. This goal directly addresses disparities in health outcomes by making healthcare more equitable. With universal coverage, everyone has the opportunity to get care they need, whether that's preventative care, routine checkups, or emergency treatments. By removing income-based barriers, the Beveridge model provides a foundation for healthier populations and more consistent health outcomes across different demographic groups. This model also prioritizes public health goals. Rather than focusing solely on treatment, this model emphasizes preventive and primary care, which are often overlooked or underfunded in more market-driven healthcare systems. Preventive care includes services like immunizations, screenings, and health education programs. By preventing health issues before they arise, these services improve population health and reduce the need for more costly emergency care and hospitalizations down the road. Something that the American healthcare system is trying to catch up in. The public health focus is one of the model's biggest strengths. Something to add there is the countries that follow the Beveridge model can work towards health objectives on a national scale, aiming to reduce common illnesses, promote healthy living, and improve life expectancy across their populations. So which countries have implemented the Beveridge model or adapted its principles to create their own healthcare systems? The United Kingdom is, of course, the classic example and our focus here in this presentation, as it has pioneered the Beveridge model through its National Health Service, or NHS, providing comprehensive, free at point-of-use service for all residents. The system has become a symbol of the Beveridge model in action. On top of the United Kingdom, we also have the Scandinavian nations. We hear a lot about them, specifically as we did in class with Finland, but also nations such as Norway, Sweden, and Denmark. These countries have taken the principles of the Beveridge model and adapted them to their own needs, emphasizing locally managed, tax-funded healthcare systems focused on equity and preventative care. It's obviously seen kind of a commonality amongst these countries and their healthcare systems. These systems are often held up as examples of how the Beveridge model can be implemented on a more localized scale while still maintaining a commitment to universal access and public health. Notably, in Italy and Spain, we see the government-managed healthcare systems that follow similar principles. Although there are slight regional variations, these countries are still grounded in the idea of universal access, funded through taxes, and emphasize both equity and preventive care. In summary, the Beveridge model provides a healthcare framework centered around universal access, equity, and preventive care. By funding healthcare through taxes and keeping out-of-pocket expenses low, this model ensures that healthcare is both accessible and affordable for everyone. Its centralized approach allows for standardized care and efficient management, making it an effective structure for countries looking to prioritize health equity. And that's all from me. I hope this gives you a clear understanding of the characteristics of this model. I will hand it over to my colleagues to continue on this presentation, and hope you enjoy. Thank you.
Hello everyone, my name is Nick Moreau, first year EMH student, and I'm going to be providing a brief summary of the characteristics of the UK healthcare system. In the previous presentation, you learned the characteristics of the Beveridge model. My part is to describe what those look like in the United Kingdom. After this presentation, I hope that you walk away with some knowledge of the UK healthcare system, as well as some knowledge of the history and structure of the UK National Healthcare System, or NHS. One disclaimer, the software I'm using only allows for one hot take, so please excuse any mispronunciation, bloopers, and mic pops. So let's first start by looking at the United Kingdom compared to other countries that have a Beveridge healthcare model. Compared to other Beveridge model countries, the UK has the highest population at 68 million. It has the lowest median age at around 40 years of age. It does have one of the higher birth rates at 11.2, and it also has the highest median household income at around $44,000. Now, the national healthcare system is funded through taxation. It provides healthcare to all of its citizens. And overall, the United Kingdom's government, of all of its government spending, 18% of that goes towards healthcare. That large 24%, I don't know what that goes towards, likely shrubberies or tea. The NHS is also one of the world's largest employers, employing roughly 1.3 million employees. Now, we don't have time to really do a deep dive of the history of the national healthcare system, but just to kind of go over some top-level points, it was founded in 1948. This founding was caused by multiple contributing factors following the conclusion of World War II. Over the years, the NHS system has evolved from restructuring in the 1970s, market-based reforms in the 1990s, and quality improvement efforts that were later introduced in the 2000s. So, as stated previously, healthcare in the UK is funded by public taxation. It's inaccurate to say that UK citizens receive free healthcare. They pay for their healthcare just through taxation. In the United Kingdom, per capita, per person, the average citizen spends $4,400 a year on healthcare. So, as tax dollars are collected, those tax dollars allocated for healthcare are distributed to the Department of Health and Social Care, DSHC. It's very similar to the United States Department of Health and Human Services. The DSHC has many responsibilities, from setting healthcare policy, oversight of the national healthcare system, medical research and innovation, social care services, but it also allocates the funding to the 4 national healthcare system directorates. The NHS is really split up into 4 different parts, including NHS England, NHS Scotland, NHS Wales, and the Health and Social Care in Northern Ireland. For this presentation, we're really just going to be focusing on NHS England. So, as tax dollars are collected, allocated to the DSHC, the DHC sets the budget and provides funding to NHS England. NHS England allocates funding to integrated care systems. These are similar to regional health authorities in the US. Integrated care systems provide primary care, specialized and secondary care, and operate hospitals. These can be a mix of either contracted services or government employees. It's also important to call out NHS Trust. NHS Trusts receive fundings either through ICS or National Healthcare System. NHS Trusts provide hospital services, ambulatory services, and they're provided in a specific budget to provide the services. The NHS Trusts are really the workhorses of the NHS system. They are government run and provide the majority of care. So, what does services look like for the average UK citizen? Well, after being a citizen and paying your taxes, most services are free. Primary care, mental health, specialist consultation, and hospital inpatient and outpatient services are all free of charge, along with most prescription medication, as long as you get them in a hospital. Which takes us to, well, what has a copay? Well, prescription medications do have a copay. Usually this occurs after you've left the hospital, and it's a very low copay. This also includes dental care, which has a copay, and optometry services. There are items that aren't covered. Cosmetic procedures are not covered under the national healthcare system, as are some alternative therapies like acupuncture and homeopathy. It is also important to note that the United Kingdom NHS system doesn't provide certain prescription drugs and certain advanced procedures that you might be able to find in other healthcare systems, namely like the United States. So if you want these services, you will have to pay out of pocket for them. So, what does healthcare services look like in the UK? How well are they doing? Well, average life expectancy in the UK is one of the lowest of Beveridge Model countries, but it's around the average of 82 years. It does have a high mortality rate of 3.3, but this is low when you compare it to non-Beveridge countries like the United States, which is around 5.5, and India, which is about 27 per 1,000 live births. Overall, though, the suicide rate in the United Kingdom is low at 7.9 per 100,000. So, despite all the good things that the NHS is doing, it is still facing some challenges. The funding has not kept up with the rising healthcare demands. The NHS system, often, if you're going in for services, you can experience long waiting times, especially if you're looking to get an appointment with a specialist or for mental health services. The aging infrastructure is having an impact on the services provided by the NHS. Many of the buildings are getting a little old, and as stated earlier, they don't have the most modern technology within their facilities. There is limited access to certain prescription drugs, and also the NHS is suffering some of the same issues that we're seeing here in America, namely staffing shortages and high demand due to a growing and aging population. These challenges are complex and interconnected, making it clear that while the NHS remains a pillar of the UK public health system, it will need strategic investments and reform to continue meeting the needs of the population. Thank you.
Hi everyone, this is Julia, and we will now transition into the successes of the Beveridge model. The 4 NHSs, England, Scotland, Wales, and Northern Ireland, operate independently but work together on public health campaigns, clinical and educational research, crisis response, and policy development. All 4 hold the principle of single-payer healthcare and share many of the same successes as a model. One noteworthy success of the system is that there are no medical bankruptcies. Since this healthcare system is single-payer, individuals are not billed directly for their care, patients are not going into debt for an emergency surgery or an unanticipated hospital stay, and people with catastrophic health events or medically complex ongoing issues are not disproportionately impacted by high medical bills. The absence of medical bankruptcies is a manifestation of one of the ways in which the UK treats their citizens' health as a right and not a privilege, because everyone, regardless of income, age, gender, race, can access free emergency care, primary care, and compulsory psychiatric care. So moving forward, the lack of medical bankruptcies definitely plays into this, but another key success of the Beveridge model is accessible care. In the UK, patients have continuous and free coverage. These patients can undergo various treatment options and obtain medications without worrying about associated high out-of-pocket costs. There's also a decreased chance of discrimination since everyone has freedom to access care as long as they are a citizen, and that continuous and free coverage contributes to mitigating social and economic disparities when it comes to obtaining care. Accessibility is also increased because care becomes standardized, as a patient's insurance does not dictate what treatments they can receive, and providers aren't managing insurance requests or claims. The Beveridge model essentially cuts out insurance as the middleman of healthcare. There are no premiums, there are no network-specific providers, which means patients have more options as to who they can see, and they can do so without concerns with that copay. This simplifies the healthcare system, making it less intimidating and more accessible for the patient. And in turn, this accessibility piece encourages patients to utilize primary care and preventative care resources instead of waiting until a health issue becomes unmanageable, requiring that emergency treatment. The last success I'm going to touch on is the contained costs of healthcare, because budgets are set at a national level. Since the government is the single buyer and there are multiple sellers, there is considerable market power in favor of the consumer, because the government, or in the case of the UK, the NHS, can negotiate lower prices. The success of the model is apparent when comparing the US to the UK. We can start by looking at overall spending, where it is evident the UK spends less on healthcare than we do over in the US. In 2022, the US spent $4.5 trillion on healthcare, accounting for 17% of the country's GDP, whereas healthcare costs in the UK was around £283 billion, or just over $366.5 billion, and account for approximately 11% of the UK's GDP. Taking this a step further, we can see the difference in cost per capita, where the US lands at around $12,500 and the UK is sitting at about $5,500. Another sector where the benefit of eliminating market competition really shines through on behalf of the consumer is looking at drug prices. In the UK, if there is a copay for prescriptions, it is £9.90, which is the equivalent of $12.84 per item, and additionally, many prescriptions are free. An example in which prescription fees remain more manageable is looking at insulin prices specifically. In 2021, the average insulin price in the US was $98.70 compared to a much lower $7.52 in the UK. These financial figures exemplify the benefits of a single-payer market where the consumer has more power compared to the pharmaceutical companies. Next, we will be moving on to challenges of the model. Thank you.
Everybody, my name is Jordan, and today I'll be discussing the challenges of the Beveridge model. Just to start, the Beveridge healthcare model, which underpins the United Kingdom's National Health Service, has faced several challenges with implementation difficulties since the inception and post-World War II era. This model, developed by economist William Beveridge, aimed to provide healthcare funded by the government through taxes, ensuring universal access. Although it has been successful in promoting equitable access of healthcare, issues still persist regarding the financial stability and workforce shortages, response adaptability, particularly like the global crisis of COVID-19. Key challenges and shortcomings, really we can start with sustainability of funding. As the population ages, the demand for healthcare increases. Funding the Beveridge model really does put a strain on public budgets. Healthcare expenditures, now at around 11% of global GDP, reflects rising demand. The challenge the model really has in delivering services without increasing taxes is one of those major areas of contention as to whether you'll decide to increase taxes or really reallocate funds from other areas. Additionally, inefficiencies such as fragmented care delivery and lack of standardization really exacerbates cost without improving patient outcomes, a significant concern highlighted by the World Economic Forum. Workforce shortages. The model faces persistent workforce shortages, with the WEF projecting the global shortages to hit approximately 100 million healthcare workers by the year 2030. The UK is no exception, experiencing high levels of burnout among the NHS staff, particularly during the pandemic. Such shortages reduce the quality of care, increase wait times, thus impeding the system's goal of universal access. Additionally, there has been a slow shift to value-based care. Moving from volume-based care to value-based care health systems is essential for sustainability, yet the Beveridge model is inherently volume-focused, compensating providers for the number of services delivered rather than the patient's outcomes. This approach increases costs without necessarily improving health results, a point emphasized by health policy analysts at the World Health Organization. There's also implementation challenges. The model was introduced in 1940 by the Beveridge Report, which responded to calls for post-World War social welfare reform in the UK, aiming to eradicate the five giants, which is want, disease, ignorance, squalor, and idleness. However, implementation posed several difficulties, one of them being political resistance and cost. Establishing a universally funded healthcare system was controversial and faced resistance from those concerned about the financial burden, potential tax increases, and although the model initially gained broad support, sustainability issues did spark debate over the healthcare's funding priorities. Additionally, resource allocation. The initial implementations required extensive resource allocation from sectors like defense, industrial development, and a complex process that delayed the full restoration of the NHS's intended benefit. The catalyst for adoption to this model, the Beveridge model emerged as a societal solution to the suffering caused by World War II. Post-World War Britain recognized the widespread poverty and inequality was exacerbating health disparities, which fueled public demand for a more equitable healthcare system. This demand led to a widespread support for a government-funded system, universally accessible, which the UK did adopt in 1948 through the NHS. Additionally, for further readings, you might refer to the World Health Organization, as they do have a ton of data on this as well. And thank you guys. Hello, everybody. This is Jordan again. Next, I'll be explaining why the US might have a difficult time adopting the Beveridge model. Unlike the UK, where there was a significant post-war support for universal healthcare, the United States has a strong cultural emphasis on individualism and personal responsibility. This value system fosters resistance in government-managed systems and fuels concerns about reduced autonomy in healthcare decisions. Additionally, healthcare reform in the United States often meets opposition from powerful interest groups, including private insurers and pharmaceutical companies that have a vested interest in preserving the existing system. The World Health Organization highlights the resistance from these groups that can stall, dilute, or delay efforts towards a centralized healthcare reform system. The economic and structural challenges are that the US has a highly privatized healthcare system with deeply entrenched stakeholders and a complex network of payers and providers, which can make transitioning to a single payer tax funded system a logistical challenge. The Centers for Medicare and Medicaid Services report that the US spends roughly 17% of its GDP on healthcare, largely due to high administrative costs and profit driven care and a lack of price regulation. This transitioning to the Beveridge model would require a significant overhaul in the spending and shift away from employer based insurance coverage. The workforce and service demands that might come about. The US healthcare workforce is already under strain. The government funded system would likely lead to an increase in demand as healthcare becomes more universally accessible. According to the World Economic Forum, a similar increase in demand has been exacerbated by workforce shortages in other countries with universal healthcare. Addressing this would require significant investments in healthcare training and infrastructure to prevent further strain on healthcare workers, which is already a concern of the current system. The public perception is really the last thing, and kind of a mistrust in the government that might be a major difficulty implementing it in the United States. We as Americans know many Americans express concerns over the potential inefficiencies of government run programs in general. Research from the Kaiser Family Foundation suggests that Americans worry single payer and government led systems could lead to long wait times, limited provider choices, and rationed care. Challenges also observed in other beverage style systems, particularly when underfunded, present in the same manner. Implementing the beverage healthcare model in the US would thus require overcoming cultural resistance, restructuring the economy of healthcare, addressing workforce shortages, and improving public trust in government led health solutions. Thank you.
So I just wanted to take a moment here to state my takeaways or learnings from our project here on the Beveridge model, specifically as it applies to the United Kingdom. In my exploration of the Beveridge model, I was particularly struck by how it minimizes financial barriers, as healthcare is primarily funded through people's taxes rather than insurance premiums. This approach allows for a more equitable access, meaning people in countries like the United Kingdom don't face high out-of-pocket costs, which reduces economic inequality in their healthcare access. I also found it interesting how countries, particularly the Scandinavian countries like Norway, Sweden, Denmark, Finland, have adopted the model with local management while still prioritizing preventive care and public health goals, something that more market-driven systems often tend to underfund. Overall, the Beveridge model showcases a powerful way to make healthcare universally accessible while focusing on both cost containment and quality. Something to aspire to. So thank you.
One country that uses the Beveridge model that I am extremely impressed with is Norway. They are known for having one of the best healthcare systems in the world. Their healthcare is extremely well funded. They do have a mix of private and public funding and have impressively maintained a stable split for the past 20 years. Norway also invests significant funds in primary care and has a robust long-term care system that, in my opinion, really goes above and beyond.
Hello, everybody. One of my biggest takeaways from this model is that it works really well. It really does. However, there are some key issues, mainly the funding aspect that I'm most concerned about. I know that globally, population is on the decline. People just aren't having as many kids as they used to, meaning that there's less tax dollars really funding and funneling money into the system. So I'm very curious as to their creative solution moving forward. I know that in the past they have allocated money from the military. In the past they have allocated money from other sectors. But as the population adjusts to really take care of the large amount of the aging population, where is the funding going to be coming from? Because again, this aging population isn't going to be bringing in income. So I'm just curious to what the UK's creative solution is going to be.
Hey everybody, Nick again. Don't panic, no more graphs. One of the things I did find interesting through doing this project was the private insurance seems to be taking root in the United Kingdom. A lot of citizens are seeking private insurance on their own, and some employers are offering it as an incentive to their employees. Private insurance can usually offer shorter wait times in the NHS, different prescription drugs that aren't available, along with different procedures that the NHS may not offer. I found this interesting because in the future you might start to see a hybrid model in the UK where employer-based insurance is alongside a national healthcare system like the NHS. Thank you. That's all I have.